Dear all, thank you very much for attending this session about the oncodermatological perspectives on side effect management. We have some of the world top leaders on board here today who will introduce themselves shortly. But my name is Corina van den Hurk. I'm a researcher at the Netherlands Comprehensive Cancer Organization, and I'm involved in research on scalp cooling for 16 years already. But I'm also the co-chair of the Oncodermatology study group of the Multinational Association of Supportive Care in Cancer, so MASC. And in this study group, we perform international multidisciplinary projects all related to dermatological topics in oncology. And there's, for example, a project to improve collaboration between oncologists and dermatologists, a project to get scalp cooling registry up and running, but also projects on guidelines, for example, radiation dermatitis, nail toxicity, or hand-foot syndrome. And all with the goal to improve the patient care and supportive care during cancer treatment. So I think you all might know that oncodermatology is an emerging field, and we will hear more about this topic from our wonderful guest. So would you please introduce yourself, starting with Nicole?
Hi, Corina. Thank you guys so much for having us. My name's Nicole LeBoeuf. I'm a dermatologist by training in Boston, Massachusetts, where I am the Vice Chair of Dermatology at the Dana-Farber Cancer Institute and the Chief of Oncodermatology at the Brigham and Women's Hospital. And I started our skin toxicities program here almost 10 years ago now, because it was very obvious that patients who are undergoing treatment for cancer were having a wide variety of toxicities from their cancer treatments, from targeted therapies, from their chemotherapy, as well as radiation and things like stem cell transplantation. So through my dermatology training, it was very, very obvious that our patients were suffering while trying to prolong their lives. Their quality of life was being just destroyed from the perspective of the skin, the hair, and the nails. And so we started this program here, a skin toxicities program embedded in our cancer center to provide urgent and expert access for our cancer patients to dermatologists to try to help them along their cancer journey. So it's been a really, really wonderful experience. And it's been really wonderful to see the field of oncodermatology grow over the last decade or so. And I'm just very excited, to be here to talk about all the ways that dermatologists can really improve cancer care and cancer outcomes.
Thank you, Nicole. That sounds as a perfect example for others, indeed, how to organize the oncodermatology. But first, over to the introduction of Beth.
Hi, thanks so much for having me. I'm really excited to be with this group talking about what I know we all love, which is oncodermatology. So I'm a dermatologist in the Bronx in New York. I'm the chief of the division of dermatology at Montefiore Einstein and the director of supportive oncodermatology within the Montefiore Einstein Cancer Center, where I've been treating cancer-related toxicities since 2013. And also similar to Nicole, kind of embedded within our cancer center. So I see a broad range of toxicities in different cancer types. I practice in a very diverse community in New York City. So I see primarily patients with skin of color. And my research focus is on radiation dermatitis, where I've been specifically interested in looking at the roles of bacteria and the immune response to radiation and promoting dermatitis in cancer patients.
Yes, thank you, Beth. Ian, would you introduce yourself?
Thanks so much, Corina. So I'm Ian Tattersall. I'm an assistant professor at NYU, and I aspire to Beth and Nicole's titles, but at the moment I'm just an assistant professor. But I started our sort of targeted oncoderm program embedded in the Perlmutter Cancer Center here at NYU, where I see predominantly patients who are seen at the cancer center and having issues either related or unrelated to their cancer or their cancer therapy. And as everybody here, kind of my interest is in the development of new recognition of new toxicities, and also the development of and I think this is something I hope we'll talk about in the way that we're kind of excited to see things going, the development of new ways of addressing those toxicities, and new, frankly, and more widespread interest in addressing those toxicities.
Yes, thank you, Ian. Well, first, what are we talking about? Nicole already mentioned that oncodermatology is about skin, hair, and nail related side effects. So, can you maybe estimate the percentages of patients experiencing dermatological side effects from the several treatment modalities?
I think just about every single patient entering a cancer center who is likely to undergo treatment is a potential patient where an oncodermatologist could have a role. And that is because regardless of the treatment type, even if you're only considering wide excision for a melanoma, if you're only considering radiation, if you're only considering any version of systemic therapy, so cytotoxic chemotherapy or traditional chemotherapy, your targeted oral chemotherapies or other targeted systemic therapies or immunotherapy, each and every type of cancer treatment can cause problems on the skin, hair, and nails. So it's almost as if any patient walking through the door is a potential person who could benefit from the involvement of an oncodermatologist on their team. Obviously, there's varying degrees to which that happens, but there are some targeted therapies, for example, that cause significant skin rashes in 85 or 90% of patients who take them. Before the advent of scalp cooling, for example, many cytotoxic chemotherapy regimens caused alopecia, and it was universally accepted that patients would lose their hair. With radiation, the older regimens of radiation almost always cause significant toxicities of the skin. And now through the interesting research, including through the work done by Dr. McLellan, we're finding ways to sort of reduce the side effects of radiation. So every patient at a cancer center is a potential oncoderm patient. And our goal is to sort of change that so that in the future we can say, about a quarter of the patients who walk in the door need us. The rest of them, not so much.
So yeah, there's a very high incidence of all dermatological toxicities. And then there's also how patients experience those dermatological side effects, because I recall all the times that dermatologists at a conference show those pictures that you think, oh, what is happening here? This must be so painful, but also affecting your whole life. Can you tell something about that?
I think I can speak to this a bit and just say that your skin is what you see, right? Like most patients who are being treated for breast cancer or an internal malignancy, you can't see your cancer. It's sort of an abstract theoretical thing, but you can see your hair fall out. You can see yourself develop a rash, or you can see the scars from your surgery. And so, even more than it's the physical morbidity, which can, as Nicole said, often be substantial. This is something that you see every time you look in the mirror, and it reminds you every day that you have cancer and that this is a battle that you're fighting, or even a battle that you fought and won, but you are still dealing with the physical and psychological scars of.
So it's all about health-related quality of life. Maybe also about interruptions for treatment, and that can be interruptions indeed after skin toxicity, but also the choice to start therapy already if you know that it causes hair loss, if you know that it causes severe rashes or something like that. How do patients maybe choose for those kind of treatments if they know the huge incidence, but also the impact of those side effects?
I think that's a really good point, and we definitely know that hair loss and fear of hair loss from chemotherapy can be a major factor, especially in women with breast cancer who are planning treatment. I know that oncologists, and I'm sure we all see patients who have had their regimen selected based on choosing treatments that have less risk of alopecia, especially in communities like mine where scalp cooling isn't very accessible due to cost and lack of insurance coverage. I actually just had a friend diagnosed with cancer, and she told me that when she met with her surgeon, she said, I don't want to die and I don't want to lose my hair. And the surgeon said, what about your breast? And she was like, I didn't even think about that. And I think that's a really common experience for women with breast cancer, that they would rather lose their breasts than their hair. I think that speaks to what Ian was saying, that, the cancer, it's like, get rid of that. But, the hair is what people see. And in many people is really closely linked to their identity. So that is very traumatic. But other toxicities definitely, I think, can disrupt treatment, both from the oncologist standpoint, because they're afraid of it becoming too severe, and also from the patient standpoint, because they're uncomfortable and unhappy with their experience with their treatment. And I think that all of these situations are opportunities where dermatologists can really play a role. And I think all of us probably see all the time patients whose treatment was disrupted. And I'm like, why did you do that? Like, this was tinea, we can treat this. So I think having that access to dermatology expertise is really important in all of those situations.
Beth makes a great point that, the majority of skin toxicities are not a profound danger to health, but it can be very difficult for people who don't specialize in this kind of thing, specifically in skin, because the oncologists have so many things to worry about. It can be very difficult to parse out which ones are dangerous, which ones are not, which ones you can treat through, which ones you really have to step back. That is a big part of the clarity that we try to provide of, is this something that you do actually have to stop and back off because this is dangerous? Or is this something that, you can keep going, we can get through this? And I think also, the oncologist can benefit from guidance there, but I think the patients can too, to also just be told, this is a scary looking thing. It's not actually that scary. Like, we're going to get through this.
I was going to say, the other thing that I'd like to say about, what Beth was alluding to is there's sort of a paternalistic approach where we say, oh, it's just your hair. It's just your hair. You have cancer. You're going to die. It's just your hair. And I think there's something really important that we have to remember when we take care of our patients. And that's, we do know that 8% or so of women will choose not to have a particular chemotherapy regimen because their hair may fall out. And that certainly affects survival and outcomes if we're picking our regimens based on side effects. But if you actually talk to the patients, it's not just their hair, right? They may have small children who they're protecting from knowing that they're sick, right? And they just don't want to become a person who is known as a cancer patient. They talk about cancer eyes. I don't want to be looked at with cancer eyes. I just want to be able to go to my child's soccer game. I want to be able to bring my child to dance class. I just want to be able to live my life and beat this thing or not. Sometimes these patients have metastatic cancer and they know that they are not going to survive. They may only live 2 or 3 years. And the last thing they want is to live those 2 or 3 years with no hair, where everyone's staring at them knowing they're going to die as the patient, when they could use scalp cooling and carry on, and no one has to know until the very end. So it's not just about the hair, and it's not just vanity, and it's not just, something that may grow back. It's how they are treated in their everyday lives and how their children see them and things like that. And it's really, it bothers me when someone says, it's vanity, it's just their hair. Because it's even more profound than quality of life. It is their entire identity. And something is like, when you look at your own children, like, of course you do anything to protect your child from that fear. And so any woman who, or any man, anyone who wants to preserve their hair and to preserve their identity, when we have the science and the data to support that, we really need to make that possible and accessible, across the whole range of the patient spectrum, I think. It's just, again, I can't stress enough that it's not just vanity.
Yeah. So there's an important role for you as an oncodermatologist to share information also with oncologists, with radiation oncologists, with the patients, etc. I also hear the statement about prevention of side effects, and there's also the treatment when they are already prevalent. So what role can you take as an oncodermatologist mainly to prevent those side effects?
Well, I think that kind of speaks to the kind of the broad picture goal of oncodermatology, which is education outside of the field of dermatology, right? We tend to have a more reactive role in that we see patients once they get skin rashes and it occurs to someone to refer them to dermatology. But I know Nicole and Dana-Farber are doing a lot of kind of more ambitious and really important kind of anticipatory things to sort of identify patients that might be having derm side effects and kind of nudge the team that maybe they should get somebody on board. And that, it fundamentally requires a multidisciplinary approach, because the dermatologist is never the first person that you see for your cancer. So if we're looking towards preventing these things from happening, or doing our best to ameliorate them ahead of time, it needs buy-in, and it needs a recognition broadly that this is important.